Now, let's begin with high-yield facts in obstetrics. The basics of pregnancy include several important terms and concepts that are central to understanding the physiologic processes of pregnancy. Gravidity refers to the number of times a woman has been pregnant. Parity refers to the number of pregnancies that led to a birth beyond 20 weeks gestational age or an infant weighing more than 500 grams, which is approximately 1 pound and 2 ounces. In prenatal assessment, the TPL system is used to express the number of term deliveries, T, the number of preterm deliveries, P, the number of abortuses, and the number of living children, L. Embryonic age refers to the number of weeks and days since fertilization, which is usually unknown. Gestational age, or GA, is the number of weeks and days measured from the first day of the last menstrual period, also known as the LMP. Gestational age can also be determined by several methods. Fundal height, which measures the distance from the pubic symphysis to the top of the uterus, reaches the level of the umbilicus, approximately 22 centimeters, at 20 weeks of gestation and increases by about 1 centimeter per week thereafter. Fetal heart tones can be detected by Doppler at approximately 10 to 12 weeks of gestation. Quickening, which refers to the first appreciation of fetal movement, typically occurs at around 16 weeks for multiparous women and around 20 weeks for primiparous women at the earliest. Ultrasonography is another important tool for determining gestational age. The most accurate dating method in early pregnancy is measuring the fetal crown rump length, or CRL, between 6 and 12 weeks. From 13 weeks onward, biometry is preferred, using measurements such as biparietal diameter, femur length, and abdominal circumference. A key fact to remember is that a patient described as G3P1 has had 3 pregnancies in total, but only 1 birth beyond 20 weeks of gestation, and or an infant who weighs at least 500 grams. The diagnosis of pregnancy is primarily based on detecting beta-human chorionic gonadotropin, or beta-HCG, which is a standard marker for confirming pregnancy. This hormone can be detected in both serum and urine, but serum beta-HCG is more sensitive and preferred when the menstrual period is less than 1 week late. Beta-HCG is produced by the placenta and reaches its peak level of about 100,000 milli-international units per milliliter by around 10 weeks of gestation. Levels then decrease throughout the second trimester and plateau during the third trimester. In early pregnancy, beta-HCG levels normally double approximately every 48 hours. A failure of these levels to double within that time frame is concerning for possible miscarriage or ectopic pregnancy. A key fact is that a quantitative serum beta-HCG test should be obtained for several reasons. To help diagnose an ectopic pregnancy and follow the trend for resolution after treatment. To help diagnose a miscarriage, to monitor after treatment of trophoblastic disease, where rising levels are concerning for choriocarcinoma, and to screen for fetal aneuploidy. Ultrasonography is also used to confirm an intrauterine pregnancy. A gestational sac can typically be visualized on transvaginal ultrasonography by around 5 weeks of gestation, or when the beta-HCG level is in the range of 1,500 to 3,500 milli-international units per milliliter. Transabdominal ultrasound is generally reserved for second and third trimester measurements, where it is used for assessing fetal growth, anatomy, and well-being. Physiologic changes in pregnancy occur to increase perfusion to the fetus, optimize maternal-fetal gas exchange, and prepare the maternal body for delivery. These changes affect multiple systems. In the cardiovascular system, stroke volume increases to a maximum at about 19 weeks and then plateaus. Heart rate gradually increases by around 20%, and cardiac output rises rapidly by 20%, then increases an additional 10% by 26 weeks. Peripheral vascular resistance progressively decreases to term, while blood pressure decreases by about 10% by 34 weeks and then returns to pre-pregnancy levels. Peripheral venous distension increases progressively to term, and the rise in stroke volume may cause a physiologic systolic flow murmur. These changes occur because an increase in stroke volume and heart rate leads to increased cardiac output, while elevated progesterone decreases peripheral vascular resistance and blood pressure. Blood volume increases by about 50% in the second trimester, and fibrinogen levels also increase. Hematocrit decreases slightly due to dilutional anemia, and platelet count may decrease mildly. The increase in fibrinogen and clotting factors 7 and 8, along with decreased protein S, results in a hypercoagulable state, reducing intrapartum blood loss risk. Plasma volume rises more than red blood cell mass, causing dilutional anemia. In the pulmonary system, tidal volume increases significantly, while respiratory rate and vital capacity remain unchanged. Expiratory reserve volume gradually declines. Dyspnea can occur due to uterine pressure on the diaphragm. Pregnancy is associated with respiratory alkalosis with metabolic compensation because progesterone increases tidal volume and alveolar ventilation. In the renal system, renal blood flow increases by 25% to 50%, and glomerular filtration rate rises early in pregnancy and then plateaus. Serum creatinine and blood urea nitrogen decrease due to enhanced clearance. Mild hyponatremia, about 4 to 5 milliequivalent L below pre-pregnancy levels, occurs due to dilution and increased antidiuretic hormone secretion. Urinary frequency and glucosuria are common findings. In the gastrointestinal system, reduced esophageal sphincter tone and delayed gastric emptying lead to reflux. Decreased gastrointestinal motility causes constipation, while decreased gallbladder motility increases the risk of gallstones. Reduced venous return can lead to hemorrhoids. In the musculoskeletal system, low back pain is common in the third trimester due to increased uterine pressure and relaxation of ligaments and joints. In the skin, hyperpigmentation occurs, including chloasma or melasma, which is a patchy brown discoloration of the face, as well as linea nigra and nipple hyperpigmentation. In the endocrine system, estrogen, progesterone, and prolactin progressively increase. Beta-HCG rises, peaks at around 12 weeks, and then declines until a plateau is reached at approximately 24 weeks. Total T3 and T4 increase, while thyroid-stimulating hormone decreases slightly due to negative feedback. Thyroid-binding globulin levels increase in response to estrogen, which leads to more total T3 and T4 being bound, but free T3 and T4 levels remain unchanged. Prenatal care and diagnostic testing. The goal of prenatal care is to prevent, diagnose, and treat conditions that can lead to adverse fetal or maternal outcomes in pregnancy. Expected weight gain, nutrition, and exercise recommendations are outlined in Table 2.10-2. Maternal failure to gain appropriate weight is associated with fetal growth restriction, whereas excess weight gain is associated with diabetes. Recommendations for standard prenatal care. Weight gain. Guidelines for weight gain according to Pre-Pregnancy Body Mass Index, BMI, are as follows. Underweight women with a BMI less than 18.5 should gain 12 to 18 kilograms or 28 to 40 pounds. Women with an acceptable BMI between 18.5 and 24.9 should gain 11 to 16 kilograms or 25 to 35 pounds. Overweight women with a BMI between 25 and 29.9 should gain 7 to 11 kilograms or 15 to 25 pounds. Obese women with a BMI greater than 30 should gain 5 to 9 kilograms or 11 to 20 pounds. Nutrition. Guidelines for nutritional supplementation include an additional 100 to 300 kilocalories per day during pregnancy and an additional 500 kilocalories per day during breastfeeding. Folic acid supplementation should be 400 micrograms daily for all pregnant women, or 4,000 micrograms daily if there is a history of neural tube defect or maternal use of valproate or carbamazepine, as folate supplementation reduces the risk of neural tube defects in all reproductive age women. Additional nutritional supplements include iron and calcium. For vegans or individuals limiting meat or dairy intake, Additional supplementation with vitamin D and vitamin B12 is recommended. Exercise. Pregnant women should engage in 30 minutes of moderate exercise daily, while avoiding contact sports or activities with a high risk of falling or abdominal trauma. Harmful substances. Pregnant women should avoid fish with high mercury levels, limit caffeine intake to moderate amounts, avoid uncooked meat, fish, and eggs, and avoid unpasteurized dairy products. Screening for Group B streptococcus is done using a rectovaginal swab at 36 to 38 weeks of gestation. Intrapartum prophylaxis is indicated for patients with a positive GBS rectovaginal swab at 36 to 38 weeks. Those with GBS bacteriuria or urinary tract infection at any time during pregnancy, and those with a prior infant who had early-onset GBS sepsis. It is also indicated for patients with unknown GBS status who present with labor before 37 weeks, intrapartum fever, or rupture of membranes lasting more than 18 hours. Intrapartum prophylaxis consists of intravenous penicillin, regardless of the mode of birth. For patients with a low-risk penicillin allergy, a first-generation cephalosporin is used. For those with a high risk of anaphylaxis, clindamycin or vancomycin is recommended. Prenatal diagnostic testing follows a structured schedule throughout pregnancy. Prenatal visits are scheduled every 4 weeks from weeks 0 to 28, every 2 weeks from weeks 29 to 35, and weekly from week 36 until birth. At the initial visit, hematologic testing includes a complete blood cell count and type and screen to determine Rh status. Infectious disease testing includes urinalysis and culture. Rubella antibody titer, hepatitis B surface antigen, hepatitis C antigen, rapid plasma reagent or venereal disease research laboratory test, cervical gonorrhea and chlamydia testing, purified protein derivative test, HIV testing, and tuberculosis testing. A pap smear is performed to check for cervical dysplasia, and vaccination status for hepatitis C and varicella is reviewed based on history. Additional testing, such as hemoglobin A1c or sickle cell screening, may be indicated. Genetic screening is discussed for Tay-Sachs disease, cystic fibrosis, and spinal muscular atrophy. From 10 to 22 weeks, aneuploidy screening is performed using one of several options. Cell-free DNA screening is the most sensitive and specific test available for trisomies 13, 18, and 21, and is accepted as a primary screening option. The full integrated test includes serum pregnancy-associated plasma protein, collected between 11 and 14 weeks, crown rump length measured between 10 and 14 weeks, and a quadruple screen in the second trimester measuring HCG, inhibin A, alpha-fetoprotein, and unconjugated estriol. The combined test includes beta-HCG, PAP-A, and measurement of nuchal translucency between 10 and 14 weeks. At 18 to 20 weeks, ultrasonography is performed for a full anatomic screen. Between 24 and 28 weeks, a 1-hour 50-gram glucose challenge test is done to screen for gestational diabetes, and, if positive, is followed by a 3-hour 100-gram glucose challenge test. Between 28 and 30 weeks, Rh, D antigen, immune globulin is administered to Rh-negative women after an antibody screen. Between 35 and 37 weeks, a Group B streptococcus culture is performed and a repeat complete blood count is obtained. Between 34 and 40 weeks, high-risk patients may undergo repeat testing for cervical chlamydia and gonorrhea, HIV, and syphilis using the RPR test. Rh immune globulin is administered to any unsensitized Rh-negative woman during any event that may cause fetal-maternal blood mixing, such as spontaneous abortion, placental abruption, or abdominal trauma, even if the gestational age is less than 28 weeks. Quadruple screening consists of 4 elements: maternal serum alpha-fetoprotein, MSAFP, inhibin A, estriol, and beta-HCG. In trisomy 18, all 4 markers, MSAFP, estriol, inhibin A, and beta-HCG, are decreased. In trisomy 21, MSAFP and estriol are decreased, while inhibin A and beta-HCG are increased. MSAFP is produced by the fetus and enters the maternal circulation, with results reported as multiples of the median, moms. Accurate gestational dating is crucial for correct interpretation, as multiple gestations and uterine fibroids may cause discrepancies between uterine size and gestational age. MSAFP is rarely tested alone because quadruple screening has higher sensitivity for detecting chromosomal abnormalities. An increased MSAFP level greater than 2.5 moms is associated with open neural tube defects such as anencephaly and spina bifida, abdominal wall defects like gastroschisis and omphaloceal, multiple gestation, incorrect gestational dating, fetal death, and placental abnormalities such as placental abruption. A decreased MSAFP level less than 0.5 moms is associated with trisomy 21, trisomy 18, and incorrect gestational dating. A key fact to remember is that trisomy 18 presents with decreased AFP, decreased estriol, markedly decreased beta-HCG, and decreased inhibin A, summarized as still underage at 18. Another key fact is that trisomy 21 presents with decreased AFP, decreased estriol, increased beta-HCG, and increased inhibin A, summarized as 2 up, 2 down. Nuchal translucency screening is recommended between 9 and 14 weeks of gestation. The combination of pregnancy-associated plasma protein A, PAP-A, nuchal translucency measurement, and free beta-HCG can detect approximately 91% of Down syndrome cases and about 95% of trisomy 18 cases. The advantages of nuchal translucency testing include earlier availability compared to chorionic villus sampling, CVS, and being less invasive than CVS. Chorionic villus sampling, cell-free fetal DNA testing, and amniocentesis each have specific advantages and disadvantages. Cell-free fetal DNA testing can be performed from 10 weeks of gestation and involves isolating fetal DNA from maternal blood sample. It is non-invasive and genetically diagnostic, but may be limited by low fetal DNA concentration in the maternal circulation. CVS is performed between 10 and 12 weeks by transcervical or transabdominal aspiration of placental tissue. It is genetically diagnostic and available earlier than amniocentesis, but carries a 1% risk of fetal loss and cannot detect open neural tube defects. Limb defects are associated with CVS performed before 9 weeks, and complications can include premature rupture of membranes, chorioamnionitis, and fetal-maternal hemorrhage. Amniocentesis is performed between 15 and 20 weeks of gestation. The procedure involves transabdominal aspiration of amniotic fluid using an ultrasound-guided needle. It is genetically diagnostic and can detect open neural tube defects, as well as assess fetal lung maturity and intrameiotic infection. It is indicated when there is concern for fetal genetic disease based on abnormal aneuploidy screening or ultrasound findings. In Rh-sensitized pregnancies, to determine fetal blood type or detect fetal hemolysis, and to evaluate fetal lung maturity. A lecithin to sphingomyelin ratio of 2.5 or greater, or the presence of phosphatidylglycerol during the 3rd trimester, indicates lung maturity. Amniocentesis can also assess for intrameiotic infection through gram stain and culture. Teratology refers to the study of congenital malformations and the causes of developmental abnormalities in the fetus. Major defects are apparent in about 3% of births and in roughly 4.5% of children by 5 years of age. Various drugs and chemicals are known to cause teratogenic effects, as outlined below. Angiotensin-converting enzyme inhibitors can cause fetal renal tubular dysplasia and neonatal renal failure, oligohydramnios, fetal growth restriction, and lack of cranial ossification. Alcohol exposure during pregnancy can lead to fetal alcohol syndrome, characterized by growth restriction before and after birth, intellectual disability, midfacial hypoplasia, smooth philtrum, and renal and cardiac defects. Consumption of more than 6 drinks per day is associated with a 40% risk for fetal alcohol syndrome. Amphetamines are associated with preterm delivery, placental abruption, preeclampsia, fetal growth restriction, and fetal demise. Androgens may cause virilization of female fetuses and advanced genital development in male fetuses, most commonly resulting from maternal litiomas. Carbamazepine is associated with neural tube defects, fingernail hypoplasia, microcephaly, developmental delay, and fetal growth restriction. Cocaine exposure can lead to bowel atresias and congenital malformations of the heart, limbs, face, and genitourinary tract, as well as microcephaly, fetal growth restriction, and cerebral infarctions. Diethylstilbestrol, also known as DS, can cause clear cell adenocarcinoma of the vagina or cervix, vaginal adenosis, abnormalities of the cervix, uterus, or testes, and possible infertility. Lead exposure increases the rate of spontaneous abortion and stillbirth. Lithium use during pregnancy can result in congenital heart disease, particularly Ebstein anomaly. Methotrexate exposure increases the rate of spontaneous abortion. Organic mercury exposure can cause cerebral atrophy, microcephaly, intellectual disability, spasticity, seizures, and blindness. Phenytoin is associated with fetal growth restriction, intellectual disability, microcephaly, dysmorphic craniofacial features, cardiac defects, and fingernail hypoplasia. Radiation exposure can cause microcephaly and intellectual disability. However, medical diagnostic radiation delivering less than 50 milligray to the fetus poses no teratogenic risk. Streptomycin and kanamycin can cause hearing loss due to cranial nerve 8 damage. Tetracyclines can cause permanent yellow-brown discoloration of deciduous teeth and hypoplasia of tooth enamel, although these effects are rare with doxycycline, which is generally considered safe to use in pregnancy. Thalidomide exposure causes bilateral limb deficiencies, onotia and microtia, and cardiac and gastrointestinal anomalies. Trimethadione and paramethadione exposure can cause cleft lip or cleft palate, cardiac defects, microcephaly, and intellectual disability. Valproic acid is associated with neural tube defects, such as spina bifida and minor craniofacial defects. Vitamin A and its derivatives increase the rate of spontaneous abortion and can cause microtia, thymic agenesis, cardiovascular defects, craniofacial dysmorphism, microphthalmia, cleft lip or cleft palate, and intellectual disability. Warfarin exposure, remembered by the phrase, wages war on the fetus, can cause nasal hypoplasia and stippled bone epiphyses, developmental delay, fetal growth restriction, and ophthalmologic abnormalities. Congenital infections. Congenital infections can occur at any time during pregnancy, labor, or delivery. These infections can lead to a range of complications and abnormalities in the newborn. Common sequelae include premature delivery, central nervous system, CNS, abnormalities, anemia, jaundice, hepatosplenomegaly, and growth restriction. Mnemonic torches. The most common pathogens involved in congenital infections can be remembered by the mnemonic torches, which stands for T. Toxoplasmosis, R. Rubella, C. Cytomegalovirus, H. HIV, S. Syphilis, Hes, herpes viruses, herpes simplex virus, and varicella zoster virus. These pathogens are the major infectious agents responsible for congenital infections and their associated complications in the fetus and newborn. Diagnosis and treatment of common congenital infections. Toxoplasmosis is transmitted transplacentally, and primary infection occurs via consumption of raw meat or contact with cat feces. Symptoms include hydrocephalus, intracranial calcifications, and chorioretinitis. Diagnosis is made by serologic testing and the presence of ring-enhancing lesions on MRI. Treatment involves pyrimethamine plus sulfadiazine. Prevention includes avoiding exposure to cat feces or uncooked meat during pregnancy. Rubella is transmitted transplacentally in the first trimester. Symptoms include a purpuric blueberry muffin rash, cataracts, intellectual disability, hearing loss, and patent ductus arteriosus, PDA. Diagnosis is made by serologic testing. Treatment is symptomatic. Prevention is achieved through immunization before pregnancy and vaccination of the mother after delivery if serologic titers remain negative. Cytomegalovirus, or CMV, is primarily transmitted transplacentally. Symptoms include a petechial rash and periventricular calcifications. Diagnosis is made by urine culture and polymerase chain reaction, PCR, testing of amniotic fluid. Treatment involves postpartum ganciclovir. There is no known method of prevention. Herpes simplex virus, or HSV, is transmitted most commonly during intrapartum if the mother has active lesions. Transplacental transmission is rare. Symptoms include skin, eye, and mouth infections and potentially life-threatening central nervous system or systemic infection. Diagnosis is made by serologic testing. Treatment consists of acyclovir administration at 36 weeks until delivery. Prevention involves performing a cesarean section if lesions are present at the time of delivery. Human immunodeficiency virus, or HIV, is transmitted in utero, at delivery, or via breast milk. Symptoms are often asymptomatic but may include failure to thrive, bacterial infections, and increased incidence of upper and lower respiratory diseases. Diagnosis is confirmed by enzyme-linked immunosorbent assay, ELISA, and Western blot testing. Treatment consists of highly active antiretroviral therapy, or HAART. Prevention includes the use of azithromycin, AZT, or nevirapine in pregnant women with HIV, elective cesarean section if the viral load is greater than 1,000, treatment of infants with prophylactic AZT, and avoidance of breastfeeding. Syphilis may be transmitted intrapartum, and transplacental transmission is also possible. Symptoms include maculopapular skin rash, lymphadenopathy, hepatomegaly, and snuffles, which is mucopurulent rhinitis. Additional findings include osteitis. Late congenital syphilis presents with saber shins, saddle nose, central nervous system involvement, and Hutchinson triad, which includes peg-shaped central incisors, deafness, and interstitial keratitis. Diagnosis is made by dark field microscopy, VDRL or RPR, and fluorescent treponemal antibody absorption, FTABS, tests. Treatment involves administration of penicillin, and if the patient is allergic, desensitization should be performed before giving penicillin. Prevention includes administering penicillin in pregnant patients who test positive. Zika virus is transmitted transplacentally. Symptoms include microcephaly, craniofacial disproportion, and neurologic and ocular abnormalities. Diagnosis is made by Zika RNA detection. There is no specific treatment. Prevention involves avoidance of tropical mosquito-infested regions. Key fact: pregnant patients should not change a cat's litter box to prevent exposure to toxoplasma.